mute and just make sure that you stay on mute during the during the news conference. We will make sure we also have a recording for you. And in the chat, we'll have Dr. Todd Vento's title for your stories. All right, thank you everyone for joining us today. My name is Glenn Beebe with Intermountain Healthcare's Media Relation team. We are joined today by Dr. Todd Vento. He is an infectious disease physician here at Intermountain Healthcare. He's going to talk a little bit about what we saw over the holiday season and kind of what we are both expecting and preparing for as we go both into New Year's and into January. So Todd, Dr. Vento, I will turn it over to you. Thank you.
Thanks, Glenn. Good morning, everyone. Hope everyone had a very pleasant and safe and peaceful holiday. Just wanted to do some brief updates and talk on touch on a few key items I think that have been circulating in terms of population's interest in some of the things associated with the COVID-19. Really what I'd say up front is that our trends right now are not necessarily as reliable in terms of interpretation, mainly because we had a lower number of testing and lower reporting. We had a Department of Health was actually off on the 25th, so they combined the 25th and the 26th case count. So we won't be able to really trend what happened in that short period of time, but we'll be looking at those numbers more closely over the next 1 to 2 weeks after the holidays. And we'll talk about that a little bit more. So heading into the holidays, we actually were hovering around a test positivity rate of about 24+%. That's actually top 10 for the country in terms of states and percent positivity. So we're certainly concerned because that represents a high level of community transmission, and hence why we're constantly monitoring the situation to see if there's any additional measures that we need to take to address that. I will say that hospitalization numbers overall have plateaued and declined over several weeks, and while the nation actually had a surge within a surge, so we have a fall surge and then we had a post-Thanksgiving surge for the United States, we didn't see that quite that level of increase in cases after Thanksgiving as we were fearing or concerned about in Utah, which is very good. And so that was reflected in our hospitalizations being in the high 400s heading into Christmas holiday, when they had been up to high 500s, even close to 600 prior to that. So basically, in terms of our trends, we'll be monitoring that over the next few weeks to see what the effect of the holiday gathering was. And honestly, we're not outside of that holiday gathering period because we have New Year's coming up. And our main concern with holiday exposure is the fact that Christmas will be different than Thanksgiving because it's an extended period of exposure, more people interacting. So all of those things, time with others and time with more people in close contact, can increase the risk for exposure. And so we'll just be looking at those trends in the next couple of weeks, really, to see what they show. I'll touch upon a few other items. In terms of vaccinations, the state's approximately at 17,000 in terms of number of total doses that they've given. Intermountain, I believe, is over 7,000 and counting. That includes both the Pfizer vaccine and the Moderna vaccine that have been actually given to frontline healthcare workers as part of the phase 1A portion of the vaccine plan or vaccination plan. We haven't had any real significant trends in terms of significant adverse effect trends. Most common reported complaint that's being monitored closely by our vaccine teams is that they have a sore arm, and that lasts maybe a day or less is what's been reported mostly. We'll comment briefly about the reports of the mutated or mutant or variant strain or lineage of COVID-19. So England has had identification of a new strain with multiple mutations in the spike protein component of the virus as well as other portions of the virus. And today, as of yesterday, actually, approximately 50% of COVID virus tests in Utah are felt to be that strain. So that is a concern in terms of spreading of another strain across the world. And hence, you've seen a travel ban for individuals from the UK in the last 48 to 72 hours. That strain has been already identified in multiple countries in Europe and in Japan and now Africa and Canada. And also there's another strain that's very similar mutation, but a different strain in South Africa. Why is that important? Well, basically what that means is the virus has been selected to actually change, and that's what viruses do. So that virus is saying, I want to actually change myself to continue to survive. And so that mutation is felt to actually allow that virus to transmit easier. It actually binds to the receptors on human cells more tightly, and it needs less virus to actually get into the body. Therefore, it's more easily transmitted. And so you can imagine that's a concern for us in public health and for taking care of patients and our population. But I will say a couple things that are positive in the last 24 hours is that they've looked at individuals who've received the vaccines that are already out under emergency use authorization to see which antibodies they have developed, and those antibodies have shown that they can neutralize even the variant strain, so that's good news. They've also looked at the vaccines that are coming out soon, in particular the Oxford AstraZeneca, and also it looks like the vaccine actually makes the patients actually develop antibodies that can neutralize that variant strain as well. And really the summary message of that, I will say, is the virus actually mutates when it actually is replicating a lot in communities, which means we have a lot of spread, and therefore the virus actually makes more and more copies, and eventually there'll be errors and therefore mutations, and those mutations help it survive. So what does that mean we should do? We should do exactly the same thing we've been telling people to do for the last 10 months, which is wear a mask, good hand hygiene, good respiratory hygiene, limiting your gathering, and limiting your distance, using your physical distancing. And those measures work for the original COVID strain and all mutation strains so far that we see. So no change to the guidance that's recommended there. I will say, last note on that is that you'll see more data from the United States in the next couple of weeks, in particular this week from LA County with the California surge to find out whether that strain is circulating more broadly in the United States. So far it has not been documented, but it's felt to be here. Lastly, I just want to point out a few things on final messaging is that we're taking measures, even though we have lower cases at this point and lower hospitalization numbers overall compared to, say, a month ago, we're still using our contingency planning measures to look at where we can load level patients within our hospitals, within our units and wards within each hospital, and also looking at ways that we might be able to augment staffing in critical units such as our ICUs, where our rate limiting step is really the fact that we can't make more people. We can certainly modify how we use the beds and convert certain beds to an extent, but we can't make new staff, as you've all heard before. And so we're still looking at how we can actually use other staff in other roles, say, a clinician who typically works in the ward, but maybe works in the ICU now, and those kinds of measures. So important thing will be the next few weeks and watching our trends. And I will say for the country, and Utah as well, in the next 2 to 3 months are really going to be important. And even though this is wonderful news about the vaccine and how it's being well tolerated and how it has great efficacy, the fact is that those preventive measures do not change. Even with a vaccine well into 2021, the measures that we recommend for so long still apply regardless of whether you got the vaccine or not, for many reasons, many of which we've already discussed. But developing the immunity takes time. Not everyone will have the vaccine. And so it's really important that we continue to hammer home that message so that we can get through this and really not get ahead of ourselves. We're not quite at the finish line, obviously, just by having a vaccine. So I'll stop there and open it up to questions. Glenn, if you want to direct.
Thank you very much, Dr. Vento, for that. And if you have any questions, if you're with the media and you have any questions, please put your just your name, the organization you're with, and your question, and we will get to those in the chat. The first one is from Chris Reed with the St. George News. He says, we know we will need to keep masks on and social distance for a while, even after the vaccine, but hypothetically, if someone is vaccinated and the virus is still in their system, can they transmit it to others?
Yeah, so if someone is vaccinated and they've made antibodies and have a what's considered a solid immunity to the virus, and they would likely not get the virus. That said, the studies for the vaccine actually showed that the severity of cases and the likelihood of hospitalization were lower, and the data for whether or not there is still the possibility of those individuals who have been vaccinated having asymptomatic infections, but not developing uh, more severe illness, that's the question that remains to be answered, and that data will come forth. But if the vaccine actually is able to provide an immunity that prevents an infection whatsoever, the vaccine itself does not, make you make a virus. It makes you make antibodies to the virus to either stop the virus from coming in or to stop the virus from causing you to have a more severe illness. And so all that data is not out yet in terms of how Pfizer's vaccine and the Moderna vaccine, which are both the mRNA vaccines, they know that they both make antibodies that neutralize the virus, but the original efficacy data was on whether it stopped individuals from having actual clinical symptomatic infections. So we still need to have the information on whether it actually protects or doesn't protect against asymptomatic infections. And that data is forthcoming.
Gotcha. We also have another question here from Carter Williams. Is there any indication why people aren't getting tested and when we can expect testing numbers to rebound to the numbers we saw pre-holiday season?
Yeah, I don't have we call it causal association or the reason why people don't do things, but we certainly have seen the trends in the past. We see this very on a smaller scale. On Sundays or Mondays, we see lower numbers. Folks sort of, wait, don't necessarily go in. Then if they're out actually starting the work week and they think, oh, I think I should get tested or I'm having symptoms, we certainly believe that those are some of the reasons. So the same kind of concept after holidays, we've seen that in the past where the numbers are down right away. I mean, the numbers yesterday were, very low, which, folks kind of, for lack of a better word, waking up from their slumber after the holidays and then maybe on, say, Tuesday or Wednesday, start thinking, okay, I'm going to go get tested. That's not unusual for other respiratory illness surveillance as well, after weekends and after, time off and holidays. So that's really what we believe accounts for lower testing. And certainly we had some changes in our reporting with the Department of Health being closed on Christmas Day and combining the numbers. So it's not really possible to compare right now the last 3 or 4 days to what happened the week before. So we knew we had a 7-day rolling average of like 2,400 cases last week or 2,500 cases. And I will say that the 7-day rolling average will be probably off a little bit and maybe not as accurate as accurately reflecting what's really out in the community for a little while. So probably towards the end of the week, I would say just remember that when you're interpreting the 7-day rolling average in the next week, that those few days where we had lower testing will reflect that. So whenever you look at those stats, look at the number of tests that were done, look at the number of cases, and look at the average, and you'll see you got to look at all of those. You can't just look at just the cases and the case 7-day rolling average because it won't accurately reflect a number of tests that were done.
Thank you. You mentioned that 50% of Utah cases are of a certain strain. Is that the mutated strain? That is from Paul Nelson with KSL Radio.
Yeah, I apologize if I said the word Utah. 50% of the cases in the UK, United Kingdom, 50% of the cases in the United Kingdom currently are the mutated strain. And they expect that will become the dominant strain. We have not identified in the United States a mutated strain yet. Those actions are actually being undertaken right now. In fact, Los Angeles County in particular, because of their surge in cases, are going to have more genomic testing. So when we look at COVID-19 surveillance, we just mostly look at cases and we say, positive test, negative test, and that goes to the CDC eventually through state health departments, and then we know what our cases are looking like. But that's not the genomic testing. That doesn't say what strains are out there. The US has done 40 to 50,000 tests on viruses from those samples that come from each of these states over the last few weeks. The UK, United Kingdom, has actually done about 150,000 genome tests. So they're doing more testing and they found the mutated strain. We have not found or identified that in the United States yet, but I would, I don't want to say I'd bet any money, but I would say that, we should know probably this week whether or not we have confirmed that, because it's been in many countries already. So not Utah. Utah does not have the mutated strain identified, and neither does the US as of this moment in time.
All right. And Alfredo with Telemundo says, are people who are vaccinated out of danger, or do they need the second vaccine?
Yeah, that's a great question because we want to make folks. This is our job as public health and infectious disease specialists to educate everyone on all the nuances of everything about COVID, which of course we're even learning ourselves, day by day, minute by minute at times. So there's probably some benefit and some protection after the first vaccine, but not nearly what it can be and will be after the second vaccine. So 1 to 2 weeks after the second vaccine. So with Pfizer, you get 2 doses 21 days apart. With Moderna, it's 28 days apart, 7 to 14 days after that. So you can imagine where folks should start thinking that, 2 weeks after my second dose, if I get it on time, that's when I should have some immunity. But the reality is, because we're not going to test individuals in the public, like say in a study. In a study, they would test you for antibodies, see if you made the antibodies, and then watch you for the next 1 month, 3 months, 12 months, 24 months. It's still going on to see if you get hospitalized, to see if you develop COVID, to check your antibodies to see if they disappear. All that's in the study. In us, for example, I got my vaccination on the 17th of December. Nobody's going to check my antibodies. Nobody's going to check them after the second dose on January 7th. I'll just have to hope that I developed an antibody based on the good data from the study, but I still have to practice good respiratory hygiene, mitigation measures like wearing a face shield, mask covering, and do my physical distancing. And that really goes for the duration for now. And so I would say until we get a large percentage of the American population vaccinated, which will probably be in late summer if you're going by current estimates, really we're looking at the same measures for mitigation that everyone should do regardless of whether you had a vaccine or not.
Thank you very much, Dr. Vento. And then the next question is, why did hospitalization numbers drop so sharply after Christmas? Did a couple hundred people suddenly get well enough to go home, or did some just want to go home for Christmas and may have left against doctor's advice?
Yeah, it's a good question. And again, it's hard to tease out the exact reasons for some of the decline. And actually that decline in or decrease in hospitalization numbers wasn't just after Christmas. We were already seeing that before Christmas, from the high 500s down to the high 400s, and the ICU percent capacity. We had 100% occupied for ICU and referral centers, high 90s to 100, say a couple weeks ago, and then we were in the mid 80s going into Christmas. And so I will say, while we don't have the exact cause of it, we have implemented a lot of new programs to try to keep people out of the hospital where we can. So, and that comes on many aspects of the hospitalization. So let's say you come to the emergency department and we look at you and say, hey, 8 months ago, I would have put you in the hospital right away because it's COVID, but now I can send you home on oxygen, and I can arrange that right now from the emergency department, and I can even put you on a remote patient monitoring where our folks look at monitors of your oxygenation, and we can actually tell you whether or not you have to come in or whether you're doing okay, and we check in on you throughout the day. And so that might be part of it too. We have more individuals who are not getting hospitalized that were getting hospitalized earlier in the pandemic. And that's not just Utah. That has been seen in different parts of the country. So let's say, or in other countries as well. But in New York, even if you were a relatively young patient and you came in with COVID, were short of breath, you might get hospitalized, and we watch and see what happens to you. Well, now some of those individuals in New York, they don't get hospitalized, but they have other measures to keep them out of the hospital. And lastly, in terms of length of stay in the hospital, if you're in the hospital and you're not going into the ICU, not going on a ventilator, and you're on a medicine ward, and you're looking pretty good, but your oxygen requirement is still there. Months ago, I almost said years, but months ago, those individuals will stay in the hospital until they get better. Now we're able to get them out of the hospital, do some home health in their home, where folks check on them, do some monitoring of them so that they get out of the hospital. So you can see that the length of stay numbers overall might look a lot lower, even though the cases have gone up and some of the hospitalizations have sort of fluctuated. We're finding other ways to take care of people and monitor them safely before they would have come to the hospital, or to get them out of the hospital earlier.
All right, thank you. Haley Hendricks with ABC4 News. Can you talk a little bit about what the atmosphere in the hospitals was like over Christmas, if you were there at all, and what it was like to see people without their loved ones around, and were there any special moments despite the COVID restrictions?
Yeah, and most of this I was on service last week in the hospitals and the ICUs, and it was right when we were actually coming out of the tail of being completely full. From talking to colleagues and friends over the weekend, certainly the emotional strain for them is high. There's sort of a mixed feeling or mixed emotions in that. There is a lot of there's been a lot of morale building for the staff in particular, and even expressed by the patients as well from personal experience about the vaccine coming and the hope that's on the horizon. So that's clearly something that is felt in the staff working in our hospitals, and that's been shared a lot. That said, also what's been shared is that how it was sad to watch folks who are in the hospital over Christmas during the holidays, and because of the restrictions and cautions for public health measures, is not being able to be with their family. But my staff who I've spoken with, who are hospitalists or ICU docs and nurses as well, they really made a lot of more efforts to actually to be assertive with pushing the contact for video contact, FaceTiming with the relatives, and a lot of that was actually done throughout the holiday weekend. But certainly the expression of sadness of having to be in the hospital alone during the holidays, when obviously that is like the most important time of the year when you really want to be with your family. So something that was felt by the staff and the patients.
Thank you. And Alfredo from Telemundo also says, you talked about the strength of the actual vaccine. Can you explain a little bit again? I know you had mentioned it earlier, but just how they found out that this vaccine could also protect against the mutation?
Yeah, and actually it was a big concern. There's other concerns out there about mutations is, remember, I'll just back it up a little bit. Viruses mutate, that's what they do, right? It's adapt and survive. And so it helps a virus. Honestly, if you look at trends in virus replication or growing, it helps a virus to be less angry or virulent, if you will, and not cause rapid death, because a virus needs a host. And so if it kills the host, it can't jump to another host. So it actually helps the virus if it mutates in ways under the pressure, the pressure from our vaccines, the pressure from our therapeutics, the pressure from our mitigation measures, if it actually gets better at transmitting to others. So if you're able to infect as a virus a patient and you can make the patient sick, or maybe not even sick, be asymptomatic, and last longer in the patient, then it's more likely that patient can then actually get in contact with other individuals and spread the virus to the other individuals, and then the virus just keeps living. And so that mutation really served a benefit for itself and its own survival. Now, the things that we'd be concerned about would be all these mutations happen, the more the virus grows, the more errors happen, because it's just a really simple process and you're just doing it so much and eventually something happens, and then you start getting kind of copies of copies. And so what happens is we worry, will any of those mutations specifically affect the severity of illness, which so far it doesn't look like? Will it affect the spread and transmissibility, which so far it does look like it's easier to spread? Will it affect the vaccine's ability to target that virus? So far, what has happened is they actually took serum or antibodies from patients who had received vaccine, both the mRNA vaccines like Pfizer, and even the one that's being studied right now, Oxford AstraZeneca, which is a different type of virus mechanism. And those individuals who had received those vaccines and had antibodies, they take those antibodies and see if they will kill that variant strain, and they did. Now that's low numbers, but nonetheless, that was reassuring. So right now, it's not felt that we would need a different vaccine. Now, that said, the beauty of the new technology of mRNA vaccines is that they have the platform. Now they can modify that genetic coding so that it can now produce a different antibody more easily to then attack a mutated strain. So that's actually something that they will be looking at through this genomic surveillance. And the CDC in particular has developed a new program of surveillance for genomic testing to markedly increase, really it'll be underway in January in higher numbers, and probably get higher numbers than, say, the UK. UK has been very aggressive, United Kingdom, in surveilling for these genomic variants. And so they've actually done a lot more surveillance than the United States has, in particular, when you think about how many cases we have versus how many cases they have. So one other thing I will say is that when you get a variant strain, you also want to know, will your tests, like your PCR test or your rapid antigen test, will they be able to actually identify that virus if it has different surface antigens? And so we're looking for certain markers. Well, our PCR tests, so our nucleic acid testing. It actually looks at multiple targets, and so we can still identify that virus. But that's something that the scientists, scientific community will be looking at to see if we need to modify any of our testing. So, you know, the virus is changing. We have to change scientifically. The beauty is, what we don't change is the fact that good, solid preventive measures still work against the virus. The virus hasn't mutated to be able to get through the masks easier. It just can bounce back and forth between people who aren't wearing a mask and are too close. So how do you stop that? You don't get close and you wear a mask. And that's really the beauty of our simple measures that will work if we do them.
All right, thank you. Our next question is from Michelle Telemundo. With 2020 coming to a close, how hard has this year been, and what have you had to change due to COVID? And what is your message for the community just 3 days before the start of 2021?
Yeah, I think up front, and we've been dealing with this now for really 12 months, honestly. We started in January. We were tracking in late December based on watching what was happening in public health around the world and getting those reports. In January, we started doing our own surveillance for individuals coming from China. So you think about it, it's a solid year. The good part about that is it's become sort of the norm, or it's what we do now. So we can't ignore the facts. The facts are we have a pandemic right now. We have a public health emergency worldwide. Therefore, our job is to now shift into emergency mode. I will say that most folks, when they shift into emergency mode, are thinking that they're going to be shifting into emergency mode for a couple of weeks, months. But I think that has been the biggest factor that I see in the population when I talk to patients and relatives and friends and even colleagues and their families and friends, is that, you know, folks are tired of being in that mode all the time. I think the way to look at it is to say, well, we've learned a lot. We've learned a tremendous amount, both scientifically, you know, socially. We've gotten all this data on, you know, which populations are more affected and how we can do better at helping those individuals, how we need to get better at testing. We've learned so much. And I think just like we had to accept the fact that this emergency is here, it's still here. You know, and so if it's still here, we still have to address it. And that doesn't mean to be robotic. It's definitely challenging. Emotionally, it's challenging because if you start to think ahead and think, oh, good, we got the vaccine, we're done. And then you realize, oh, we're not done. We're still doing this 3 months, 6 months, 9 months. I think doing expectation management for yourself and committing to the long haul and knowing that, hey, let's not put any real timelines on. Let's just say, this is what we have to do. This is what's in front of us. And we know what the measures we have to take. So let's continue to do them. Okay, it's our new job. For me personally, I'm doing obviously a lot more COVID work than my regular job. So there's, you know, that stressor, but that's, you know, what everyone's doing to some extent. And so I think we've accepted that. I think it's really challenging, I know, for many people, and I think you see that in our social media a lot about, you know, folks feeling like they're tired and they just want to, hey, I'm just going to get with my family because I can't, you know, I can't do these measures still. I would say, to finish off my response to your last part of your question, is let's looking ahead. You know, I don't want to use the tunnel and light in the tunnel, but I think climbing a mountain. You know, so we're climbing a mountain, and we've got a recent assist to get up this mountain with the vaccine, and so we want to get to the top of the mountain. We can see the top of the mountain, which is the period where we could actually visualize that COVID-19 transmission in our communities will drop through our measures of public health and preventive mitigation measures, like we all talked about, and with the vaccine, and getting that vaccine and keeping that education to everyone so that they are you know, willing and desiring to get that vaccine. And so I think with all of those together, we can really see that, hey, we're going to get to the top of the mountain. And that's, you know, that's something to be really hopeful for. And I think not putting a timeline on it, because when you put timeline on it, then you start thinking, well, here's the timeline. We're not there. What happened? You know, it's real life. All these other things can happen. I think just staying, you know, being disciplined, staying on target, as we say in the military, is like, you know, staying focused and keep shooting at that target. Okay, and that target is to keep doing the discipline mitigation measures, take the vaccine, which really works and is a safe vaccine, and we'll even have more vaccines. So there's a lot more assists to get us to the top of the mountain. And I think I'm very hopeful, and many of my colleagues feel the same. We at least have a lot more tools in our toolbox to use against this virus, which we didn't have it last, you know, even 4 months ago. So we're hopeful for that.
And Dr. Vento, someone is asking, these methods to keep people out of the hospital, monitoring them at home. Do you see this being something hospitals will keep doing even after the pandemic? Will patients have more options like this? Say if they have high deductible plans, could it be more cost effective?
That's a great question. And, I direct telehealth programs, and I will tell you that, we testified with other groups throughout the country in April, May timeframe to Congress to actually support funding insurance companies and Medicare funding telehealth measures. Well, same concept here. I think the acceleration of these technologies and these tools to actually help take care of patients in a safe manner is just been incredible. And so that's a little bit of a silver lining on a World Health emergency, a pandemic, is that we now have measures that have been shown to be effective and are being supported by legislation and by insurance companies. And so I do think that that will be an impetus for insurance companies. In medicine, a lot of the trends are kicked off by what the Centers for Medicare and Medicaid, or CMS, services, what they do. And then if there's support of that to actually fund these remote patient monitoring or out of hospital programs even more and more, I certainly know, from a standpoint of Intermountain as an organization is fully supportive and behind a lot of these programs. In fact, our leadership encourages the development of these in real time. And so that's actually enabled us to do these remote patient monitoring programs, or having patients go out of the hospital with other services outside the hospital to keep the hospital numbers low. And also it helps to stop spread of COVID-19 and other viruses and other diseases. So I do think that other conditions will be used for that. We'd use it for heart conditions already. Patients with congestive heart failure, we've shown in Intermountain Healthcare systems that if we monitor them outside the hospital after they're discharged, we can prevent them from having a readmission within a week or 30 days. So those have been looked at. Obstetric population, pregnant women being monitored at home instead of coming to the hospital and having to be monitored for a week in preterm labor, or in, say, certain conditions that they in the past would have been in the hospital, they can actually be monitored at home. So I personally think that we will see that, and obviously it'll depend on legislation and policies, but we'll be advocates of that wholeheartedly, for sure.
Dr. Vento, there may be some cases where people did end up getting together with family or friends over the holidays, and they may find out in the next couple of days that maybe someone they were around were sick. Can you maybe go through, not one, what should those people do if they may have been exposed to someone, and two, can you also explain why people want to hold off possibly on getting a test, and why you can possibly get some false hope if you get a negative test and you haven't waited long enough?
Thank you, Glenn, for that important question and reminder. Going back to the incubation period of the virus, it's 2 to 14 days, but most infections are probably 5 to 7 days. So if you've been in a situation where you had a high-risk exposure, unmasked, close contact, extended period, right there, that's called Christmas dinner, right? If you're not masked and you have people outside of your own home who you've all been the same and not had the virus. So if you've had those risky situations, really the first thing you ought to do is say you're at high risk for developing an infection. And that infection could be asymptomatic, because 50% of cases are asymptomatic. So right then and there, I would actually advise folks to actually take a quarantine approach and say, I should actually put myself essentially in a quarantine state and not run the risk of actually going out and exposing to others if I start to develop the infection, because it might be asymptomatic and I won't know. And so if I go and visit my grandmother, for example, I might actually cause her to be sick and get in the hospital and worse. So that would be the first thing, is that if you think you've had a high risk exposure, go into essentially a quarantine mode. And so 14 days, 10 to 14 days, depending on situation and whether you're tested. Now, the next part of that is, whether or not, if you had a high risk exposure and there's an opportunity for you to be tested, then that, I would certainly encourage that testing. And with a high risk exposure, you do have an indication for being tested. And the key there is that if you test too soon, it might show negative even though you're still incubating. So I would not test before 5 to 7 days. So I would even say if you go safe 7 days, there's a high percentage, not 100%, but a high percentage of likelihood that you will be able to find that you are positive for the infection, because we waited enough time for the virus to actually incubate and show that it's live and that you are infected, whether you have symptoms or not. So wait 5 to 7 days after a high-risk exposure to be tested, so we don't miss the infection. But at a minimum, go ahead and assume a quarantine posture and limit any outside interactions, and certainly don't go and put yourself in situations where you're going to expose others.
All right, thank you, Dr. Vento. And the next question we have is from John Reed. Do you have any concerns about people not taking the vaccine and preventing the herd immunity that may come from it? What can we do to help as many people take this as they become eligible?
Yeah, so it's a great question. And this herd immunity concept, the herd immunity calculation or estimate on what percentage of the population has to be vaccinated in order to provide this protective effect for all people, including those who are not vaccinated, because they're essentially shielded in numbers by those who have the antibodies. We're estimating now 70 to 85% of the population would probably have to get vaccinated to have this herd immunity. And so I will say this, with the new variant strain, if it has a higher transmissibility, that percentage of individuals who has to be vaccinated for herd immunity might actually be higher. Because remember, that R naught, or reproductive number, or effective reproductive number at time T, sorry for all the medical jargon, but those dictate how many people have to be vaccinated. The classic example is measles, right? If one person gets infected with measles and there's not measles immunity in the community, you can spread that to 15 to 18 people. Whereas, say, COVID-19, it might be in the ones, might be two, depending on what other measures are there. So for measles vaccine to be effective, you have to vaccinate high 90% of the population. Whereas for a virus that doesn't transmit as easily, then you can actually vaccinate a lower percentage and get herd immunity. That's how we do the calculations. So what we need to do is really, everyone who has awareness, spread the awareness. That means you to your friends, you to your family, us to our patients, us to the community, to say, look, we have a very effective vaccine on our numbers so far. We have more vaccines in the pipeline. We have lots of different vaccine options. If you have concerns about one vaccine, you might be able to get another vaccine. And we're learning about this, and it works so far. Therefore, this is our ticket out, if you will, of our current situation. And we all want to get, I think, back to a new normal. Therefore, I would press that and also share when we have data on 16,000 individuals vaccinated so far in our state and not significant adverse effects. Really, there's a successful, really almost a miracle of science that we were able to do this in a year when we didn't even know this virus existed about 13 months ago. And now we have multiple vaccines against it. So it's educating and really pushing that. And there will still be folks who have the right, individual right and preference to not get the vaccine. But the more we get it, the better. And so just because we say, oh, we have to get to 70% or 80%, oh, good, we got there. Look, we need as much safety buffer as we can. So getting as high as we can numbers in terms of vaccination is really going to be critical. So I would just push the education all the time and let folks know that. And I know it's hard in this era of misinformation. We have what's called an infodemic as well as an epidemic or pandemic. But it's really important for us to push the good, solid science information that says the vaccine is effective, it's safe, and it will actually help us back to new normal.
All right, thank you, Dr. Vento. We have had a couple of questions asking about just reaction to the state setting numbers and kind of priorities for the next round of vaccinations. I just wanted to say that that's a Utah Department of Health question, just because they set that. So we would refer to them on that question. But Dr. Vento, I did want to ask you just about kind of where we are at with current caregiver levels of vaccines. You know how many have gone out so far, and just kind of where we are in that process now that Moderna and Pfizer are being distributed.
Yeah, I don't know how close we are to saying our estimates of what percentage we've gotten to. I mean, we're not there yet. I know that's been very successful in terms of as soon as it was shipped or transported, we were vaccinating within 24 plus hours, actually 24 hours. And so that's very successful. And that's not Intermountain, that's everywhere in the state that's offering the vaccine. I haven't heard, whether or not, there's been any shift to and as Glenn mentioned, that's dictated by the state. The governors decide what's their priority of vaccination. I know that there were some changes in distribution on the Pfizer vaccine early on, and that was reported at our Department of Health meetings that we sit on for the task force. And such that we had fewer number of vaccines on a weekly basis that were estimated originally, but now there's also been other developments on additional contract for Pfizer for the nation, which should trickle down to the states as well. So I do know it's moving forward. I will say this: if we look, what I would say is that nothing, learning our lessons of COVID, nothing is set, and the plan. You got to have a plan. You can't just hope, but you got to have a plan, but the plan will change. And so I would not be surprised if some of that changes to where even if not all of the frontline workers who work with COVID have gotten the vaccine for whatever reason, then maybe they start to shift and sort of start doing the next phase. I would anticipate that would be something you might see. I'll give an example. Texas decided on their second round of vaccines to actually prioritize older patients and patients who had comorbidities ahead of, say, essential workers. Transportation, utilities, things like that. That was their decision. And the governors and individual states have that decision, and they can make those changes on the fly. And so I would just say that be prepared for that, for plans to change. Be prepared for us to, if we have success with the vaccine, be prepared that there may be additional supplies and more distribution. So right now, I think we're doing well at moving forward through the current phase one. I think if you look at national estimates, we're certainly under on what Operation Warp Speed said. Hey, we'll do this many people by December 31st. I think they said 20 million, and we're right around 2 million for the country. So we're obviously lower than expected for lots of reasons, but part of that has to do with folks developing their plan for the logistics of getting the vaccine and then distributing it and vaccinating. And so I think as we get better at that, then we'll get, I think we'll get more and more folks vaccinated sooner. And I think I will say that in places where the variant strain has had more transmission, in particular United Kingdom, they're pushing for having the vaccination plan to be accelerated even more. So I would say be flexible in your expectations. Don't be rigid in, you didn't get it by this much, what now? I expect there to be change, and I think that's what we've been doing for the last 12 months, is be flexible on the plan to adapt to what the virus is doing.
And so we actually had a clarified question, just as a infectious disease expert, as a physician, just what will it mean now that the state has set the 75 plus? What do you think that will mean for that population? We know that population has been vulnerable before, that they've been usually make up a lot of the deaths. So what will having that section of the population mean once they start getting vaccinated?
Yeah, I mean, that's really key. If you think about it, which population is most risk for severe illness, hospitalization, and death? That group. Age is probably your greatest risk factor for a severe infection, and a severe infection translates to more hospitalization and translates to more deaths. And so by doing that, you would expect, I wouldn't say immediately, obviously, it's not the way it works, right? We have to develop the immunity, you have to get the second dose, you have to wait for that development of immunity. But the sooner we start doing those things, I would say you would start to see at some point in time, probably months, not on the order of weeks, but maybe months, a even further lowering of hospitalization numbers, because that group actually accounts for more of the hospitalizations than any other group. And so that's why it kind of makes sense to target that. So if you think about, why do we vaccinate folks? Well, we vaccinate them if we can save their life, if we can save severity of disease. We vaccinate them to, say, keep them healthy in the workforce if they're critical to the workforce. So hence why the Centers for Disease Control and authorities with the United States government recommended that we get frontline COVID workers, because if we had a bunch of frontline COVID workers who were getting sick and not being able to work, then they couldn't take care of the patients. So you have to have this balanced approach to make a decision. Okay, I'm going to get some frontline workers so that we always have them. If this gets worse, if the pandemic gets worse, we've got to have people to take care of sick patients. But which patients are most sick? Well, let's vaccinate them so they're not the ones coming to the hospital. So we do a sort of win-win situation, right? We have people to take care of patients, and we have fewer patients to take care of in the hospitals. And so that's the argument. At least that's one of the arguments for making those decisions on which groups to vaccinate.
All right, thank you, Dr. Vento. And it looks like there are no more questions. So with that, we will conclude this news conference. We appreciate all of you for joining us. We will remind you that we will send up a follow-up email with a recording of this news conference that you can use, along with some B-roll if you need it. Dr. Vento, thank you so much for the update, and we appreciate you all for joining us. Have a great day.
Thanks, Glenn. Thank you, everyone.